So you brought up that hot topic of tumor mutation burden, and Checkmate 227 looked at nivolumab with or without ipilimumab, a very complicated study, almost 2,000 patients, and we've slowly seen data come out with one bite at a time. And so how are you using tumor mutation burden right now? What are your thoughts on what's being presented with Checkmate 227, and is it a regimen that you're using or excited to use in your patients with metastatic disease?
So far, we have not routinely been incorporating tumor mutation burden. One issue we have our institutional panel for mutations, which looks at 10 mutations or gene abnormalities, including all of the 4 genomic abnormalities for which there are associated therapies. And with a panel like that, we internally do not get the data that's needed for tumor mutation burden, which will be an issue, particularly if we are in a situation where it becomes clear that that this data is going to be practice changing. I think there's certainly reason for enthusiasm. I think that tumor mutation burden clearly is predicting whether or not patients will have progression-free survival. Overall survival data we're still awaiting. I think if that comes back positive, I think we are going to have to make some significant changes in terms of whether or not we how we deal with the pathology specimens. Is a 10-gene panel internally going to be sufficient if we have a group of patients who are not anticipated to benefit from who basically have a therapy that is driven by that will dictate their care. I think there's still some questions though, and I sort of share some of the concerns you bring up in your question, that the data's come out a little bit at a time, and in fact this is a concern I do have. This is a very large study where oftentimes the data we're shown is based on a very small subset of that, and so I do look forward to getting a robust data set where we can really evaluate the data in its totality. What is the added benefit of the ipilimumab, for instance, which I think is still a very interesting question, and one that I still find hard to answer with the data that's available to me.
How about, do you have access to TMB? I know at our institution we do not. We also have a small 40-gene panel that's back in a few days. What are you guys doing?
So we have the same problem, that the gene panel's like 40 or 50 genes, and I think the challenge is that, one, it doesn't encompass all the targets that we want it to in the modern lung cancer world, and we don't get the TMB. I would say that I'm starting to see more patients with Foundation Medicine testing, which was used in the study, and we're starting to send more out to that for testing, just to try and get the TMB. I've not implemented Nivo-Ipi based on the data now, and I would caution against that until we really see the overall survival benefit and updated toxicity in regards to that combination.